Good evening, ladies and gentlemen. On behalf of the Convergence Science Network partners, we would like to welcome you to this evening's event. Dr. Digital will see you now. My name is Charmaine, and I'm currently a master's student at the University of Melbourne doing my Masters of Biomedical Science.
My name is Rosie, and I'm doing the exact same thing. We're excited to have recently joined the Convergence Science Network as interns. So we're helping with the communication and growing the public's engagement of the network in the developments of biomedical science. We're really pleased to be your host this evening.
Biomedical research is an undergoing revolution in our ability to understand human biology and the cause of diseases. In this process, far more data is being generated than ever before. So not surprisingly, data analytical skills and know-how is playing an ever greater role in biomedical research.
One of the buzzwords from data analytics in biomedical and health research is machine learning. Many experts believe the future of medicine is based in data and analytics. This evening, we're delighted to have two experts in the field to share with us how they use machine learning to improve diagnosis and treatment. Professor Karin Verspoor is a professor in the School of Computing and Information Systems and is also Deputy Director at the Health and Biomedical Informatics Centre at the University of Melbourne. Trained as a computational linguist, Karin's research is primarily focused on extracting information from clinical texts and the biomedical literature, using machine learning methods to enable biological discovery and clinical decision support.
James Bailey is a professor in School of Computing and Information Systems at the University of Melbourne. Internationally, he is a leading researcher in data science with extensive experience in applying machine learning techniques to tackle challenges in health. In partnership with clinical collaborators, he has developed and deployed machine learning algorithms for real-time prediction of hospital medical emergencies, as well as algorithms for delivering automated feedback to medical students engaged in simulated surgical training.
Please give a very warm welcome to Karin Verspoor and James Bailey for tonight's presentation.
So, we are here to talk to you tonight, as we heard, about the revolution that's happening in medicine at the intersection with technology. And what we'd like to tell you about, and what I hope you leave here with, is the great opportunities that exist to radically change the way medicine is practiced, with insights that are derived from digital data and the application of computational algorithms, such as machine learning, to that data. But first, I'd like to take you on a journey to someday in the perhaps not too distant future. On this day, you are feeling unwell and you decide to make a visit to your doctor. You arrive at the medical center and are taken immediately to a small room. In this room, you are greeted by Dr. Digital. Dr. Digital is a specially trained computer program that has been designed to conduct patient interviews, including taking of the patient's medical history, and a collection of a range of physical examination variables that can be collected through devices in the room: a blood pressure cuff, a smart scale, a glucose monitor, a stethoscope. These devices can transmit their measurements directly to the doctor. Dr. Digital also has access to your medical record and so knows what diagnoses and treatments you have had in the past or what is ongoing. Dr. Digital begins the interview by asking, what brings you to see the doctor today? Sounds like a normal exam, doesn't it? And you begin to explain your symptoms. Dr. Digital takes this information in, relates it to what is in your medical record, and begins to form a hypothesis about what is ailing you. The doctor instructs you to place the stethoscope in a specific location over your heart, guided by a projection of a skeleton over your body, an augmented reality tool that signals to you exactly where to put the chest piece. The sounds that are picked up by the electronic stethoscope are converted into digital form after filtering and amplification, and are sent immediately for analysis by one of Dr. Digital's built-in algorithms. This cardiac algorithm can detect different kinds of murmurs and various heart disorders directly from the acoustic signal. The algorithm classifies your heart sounds as abnormal and alerts Dr. Digital to a high-confidence diagnosis of pulmonary stenosis. Dr. Digital uses this information to ask you several follow-up questions, guides you through taking of several additional measurements to rule out alternative diagnoses, and finalizes your diagnosis. Next, Dr. Digital scans the current clinical practice guidelines available to him, searches for relevant clinical pathways that you should be put on to guide your care, and reviews the latest research literature for additional advice on treatment options. Finally, Dr. Digital calls in the human doctor overseeing the practice. Dr. Smart is then shown a summary of the information that has been collected about you. He has explained the diagnosis that has been inferred and the reasoning underlying it, and presents the treatment options with an assessment of Dr. Digital's highest confidence recommendations. Dr. Smart reviews this information, checks for any mistakes or anything that Dr. Digital overlooked, confirms a diagnosis, and then discusses the pros and cons of the treatment options with you. You come up with a plan for next steps together. So what's inside of Dr. Digital? Most fundamentally, Dr. Digital has data and algorithms. The data that is relevant to the clinical context can include everything from individual patient-level characteristics, the results of laboratory tests and investigations, right through, as I mentioned, to the published research literature that provides the evidence base for supporting clinical decision-making. In a few minutes, James is going to elaborate on how machine learning algorithms can be applied to transform observations into diagnoses and clinical decisions. But there are other types of computer programs that are also important to the scenario I described, as in natural language dialogue and speech recognition, allowing a natural conversation between Dr. Digital and the patient, signal processing technologies that transform raw data into summarizing features, augmented reality to create a view of the patient that is shared between Dr. Digital and the patient, and data visualization and summarization in order to provide insights and critically explanations of the decisions that Dr. Digital is making. Many of these are active areas of research, some of which we might call artificial intelligence, and some of which use machine learning to enable their functionality. In our scenario, the focus was on an individual patient's data, collecting new information through a clinical interview, reviewing the existing medical record for the patient, and supporting a diagnosis or treatment decision. Before we learn more about machine learning, it's worth considering whether we can broaden our perspective from the clinical needs of the individual patient and indeed consider the notion of learning in a broader sense. Recently, there's been a move towards learning health systems, which proposes that health systems at any level of scale become learning systems when they can continuously and routinely study and improve themselves. This implies a virtuous cycle of data collection, data analysis and interpretation, feeding results of the analysis back to inform decision-making, and eventually implementing those decisions and acting upon them. The idea of a learning health system is about human learning and about system improvement, and as much about embedding learning into the culture of the health system as it is about any technical tools that support that learning. Some motivation for the learning health system comes from the large gap that can exist in translating evidence into clinical practice. It has been estimated that it can take 17 years to translate research-based evidence for the effectiveness of health interventions into clinical practice. 17 years. This has real impacts for patients and their outcomes, as well as implications for the cost of treating those patients. A lot of this lag appears to be due to the lack of policies and processes for making knowledge actionable and shareable and for promoting behavior change. The learning health system is a paradigm that seeks to change that. While this sort of learning health system doesn't require automation and doesn't necessarily imply machine learning is a key element of our ability to scale the data analysis to ever-increasing volumes of data and to provide predictive models that can inform the decision-making. In other words, machine learning is an analysis and interpretation tool that supports health system improvement. Learning health systems can be implemented at many scales, from the treatment of individual patients to reducing errors across a hospital. So let's look at a few of these in a little bit more detail and consider the ways in which machine learning can play a role. So first, at the patient level, we have access to patient characteristics. We can take advantage of personal health monitoring devices, Fitbits, anyone? But also things like glucose monitors and other devices that people are more and more increasingly carrying around in their pockets. We have data that ranges from the genome right through to the exposome. What's the exposome, you ask? The exposome is the collection of environmental factors that you're exposed to every day. It's things like where you commute from and how long that commute is. It's anything you can imagine that might impact on your health. If we can collect variables that reflect and impact your health status, then we can start to ask questions about what are our personal health risks, and we can even do self-assessment. Is the symptom that I'm experiencing this morning normal? Is it normal for me? Is it normal for the population as compared to my peers? If it's not normal, perhaps I will go and see my doctor. The doctor, as we've mentioned, can take advantage of machine learning by having tools that support clinical decision making. We can use these tools to help support medical training, and James will tell you in a few minutes about some of the work that he's been doing in surgical training. And we can use tools to review the evidence base that's available in the published literature. And that's a large part of the work that I'm involved with. Using this information, the doctor can ask questions such as, what is the likelihood that my patient has or will develop a particular condition? What is the best therapy for my patient? Weighing different options against each other. At the clinic or the hospital level, we can start to ask questions around our health services delivery and around patient outcomes, broadly construed. Are our patients receiving the right care when they need it? What kind of patterns of treatment or journey through the hospital do we see, do we observe? And how do those relate to outcomes? When we find problems in those relationships, then we can use that information to help us improve. One of the most exciting things, as far as I'm concerned, is thinking about using this learning mechanism at the healthcare system level and actually trying to use the population as a source of evidence. It's something I'll elaborate on a little bit more later. But trying to take advantage of data about large numbers of patients opens up opportunities for us to think about actually, almost unintuitively, making medicine more granular. So it's the power of large numbers that allows us to look at consistencies in variation. When we have small samples, like in a randomized controlled trial, we actually are limited by the variation, by the power of those studies. If there's too much variation and a small population, we can't find consistent or meaningful statistical patterns. So by extending our analysis to the entire population, we have the opportunity to really look for patterns that are much more narrowly defined, variables that are much more tightly specified. So we can ask some of the same questions that we might ask at the patient level, but with reference to a very broad population. What predicts health status? How do we know what's causing, what's driving particular illnesses? And then again with the treatment questions, how have different subpopulations responded to different treatment options? We can actually investigate these questions not with a controlled study, but by observing in the health record, if we have access to a lot of data, what's happening with real patients getting real treatments. So now I'll hand over to James.
Thank you, Karin. So my task in the next few minutes or so is to start talking about machine learning specifically, because after all, that's the key technology that we're here to discuss in the context of health. So This diagram is sort of an attempt to put together some of the current buzzwords that we're seeing in the media at the moment. So you've heard words like artificial intelligence, big data, machine learning. So looking at these different things, I think artificial intelligence. So artificial intelligence at the top, that's our big box. So inside artificial intelligence consists of a number of different things. One particular thing that it might consist of is you think about robots. So machines that act in an intelligent way. That's a classic sort of ingredient of artificial intelligence. To go with the robots might be using speech. They might be reading text. These are also ingredients that go into the artificial intelligence umbrella. At the same time, you've got statistics. That's the icon there that we're talking about. So statistics are a core, important part of artificial intelligence. Big data, it's everywhere. It's what is it? It's just big. It's just big data. It's a lot of data. So in the context of health, it means a lot of health data that's been collected. It might have been collected for a purpose. It might have not been collected for a purpose, but it's just available as part of the electronic medical record or similar. So assuming we can draw on the big data, we finally get to machine learning, which is this crystal ball here. And machine learning is the technology that's going to allow us to make predictions using this big data, if you like. Machine learning, if you like, is a core component of artificial intelligence. Moving on to machine learning, what we're just saying in this visualization is that we have our data, our historical data, our hospital records, our Fitbit records, whatever it is. We're feeding them into a machine learning algorithm, so that machine learning algorithm is somehow picking up on the patterns, the regularities in the data. Based on that, the machine learning algorithm will create if you like, a decision module for us. So something that allows us to make predictions, which is called a prediction model. So the output of the machine learning algorithm, it gives us this prediction model. We can ask questions to the prediction model. So is this patient at risk of this disease? That could be the question, and the answer is going to be yes, no, or some level of probability associated to that question. Conceptually, that's the sort of flow that we have, and I think one of the key excitements at the moment in the media and other places is that these machine learning algorithms have become very sophisticated, so they're very good at answering the questions that come in over here. Okay, so just to give you a very simple example, and this will be perhaps familiar to some of you, imagine we want to make some prediction. So we've got a prediction task. We want to know whether a patient, as they're leaving the hospital, are they likely to come back in 30 days? 30-day readmission. You know, if you can work out that they're likely to come back in 30 days, you might have a different treatment plan for them to try and prevent that readmission. To try and tackle this task, to use machine learning in a very simple way, we have our historical data, 500,000 patients, characteristics of those patients, how old they are, laboratory tests, blood tests, perhaps some information about heart rate, blood pressure, and so forth. And for each patient, we know what happened to them. So given these characteristics, in the past, did they end up going back into hospital within 30 days? So that's our data. That's what comes in over the left. You feed it into the algorithm. The algorithm is going to be responsible for assigning weights or credibility to the different factors that go into it. It'll look at the factors. It might combine the factors in unusual, unexpected ways. And at the end of the day, it will weight each of them and it will try to combine them in some overall measure. So in the simple case, we end up with a formula down the bottom, which is a very simple machine learning model, which is just telling us the probability that a person will be readmitted to hospital within 30 days, given that these were their characteristics. So it's quite simple that, in one sense. Just a formula, you use the formula, you do a calculation, and then you can use that information. Just to emphasise one of the requirements here, and we'll see more of this, but this idea that to get a good formula, to be able to get a formula that's accurate, we'd like to have data. It's good to have a lot of data, is the thing to bear in mind. Before we move more into the health examples, this is just to point out that machine learning it's nothing strange and mysterious. It's around us already, even though we might not be thinking that it's machine learning. So we might use Amazon to buy our books. We get recommendations. That's machine learning. Algorithm giving us those recommendations. We're watching movies on Netflix. Again, we get recommendations. That's using a machine learning algorithm. Translation, Google Translate, getting better and better and better. You've got machine learning algorithms that are allowing that to happen. Driverless cars, key components, object recognition and so forth are machine learning. And then everyone's favourite, Facebook and the social networking. What you're shown in Facebook for your news feeds and notifications, there's a machine learning algorithm behind that making predictions. So lots and lots of examples. None of these are health examples, but why not? And what could be done? What can be done in health? Before I get onto that, this slide is really just to make the point that there's a whole zoo of machine learning methods or algorithms, and they range from things that look sort of like a decision flowchart tree where you start at the top and you move down, and if the person is this and this and then this, then you're able to make a particular conclusion. So this type of machine learning model is quite easy to interpret if you give it to a human, because they can see the paths the path that's followed through the tree. The statistical formula, the second one there, that's another type of prediction model, if you like, and regression and all kinds of varieties of regression you might have come across. And then the new but not so new machine learning techniques, things known as deep neural networks. The idea that you can have machine learning algorithms that are in some sense inspired by the human brain, and they represent information in particular chunks, and each circle there is like a chunk of information. And it's really like you get all these statistical formulas together, you glue them together, and you can form a network that makes decisions. And the reason we're including them here is that these are some of the algorithms that are getting a lot of excitement recently in health. So particularly for tasks such as imaging, radiology, dermatology, you feed an image, you make a prediction. These sorts of techniques are doing extremely well in some of the scenarios. They're also very good in language and being able to infer meaning from text, or even building a chatbot. So Karin mentioned the Dr. Digital that was talking to us, a bit like a chatbot. These sorts of methods are having a lot of success for that type of task. This slide is just to make the point that we're talking a lot. Well, I'm talking a lot about predictions, but maybe we really want decisions. So the slide is really just making the point that if we want to make a decision, it does involve a prediction. So, for example, you made the decision to come here tonight to attend the talk. That was a decision. Probably you were making a prediction at the same time. Would I like the talk? Would I get something out of the talk? You went out into the cold night air, again with the prediction that it would be worth doing. So predictions are a core part of decisions, and that's really what machine learning is doing for us. It's the prediction part. The scope of machine learning is another key thing here. So I've sort of broad brush described that there's these algorithms, they make predictions, but to get them to work, you really need to be very you need to really specify what comes in, what goes out very clearly. So to use machine learning successfully, you need to know what your input factors are, so what's the data you're feeding in, and you have to be very specific, and you have to know what it is you're predicting. So if you know these things, you know the inputs very well, you know the outputs very well, then machine learning has the potential to discriminate very well between possible outcomes. So given this information about the patient, how old they are, their gender, their lab results, you could get the machine learning model to compute the probability of an event. So very well specified inputs, very well specified outcome, probability of a particular event. Likewise in imaging. Given a particular type of image, you can be making a particular prediction about whether it's cancerous or benign. What you might want to avoid, that's the last point there, is situations where you're perhaps not so sure what the input data is. You're not so sure what it is you're not trying to predict. So the example we've got there, you've got Dr. Digital, and Dr. Digital is trying to work out, is the patient seriously ill? But what source of information is it using? We haven't specified clearly enough exactly what it's using. A real clinician might be looking at the patient, might be looking at their body language, might be talking to the family members, might be doing all sorts of things, data which is not available to the machine learning algorithm. So I think the key message really just from that slide is that you have to be very specific about what comes in, what goes out to have success. Hopefully implicit in the scenario that Karin has talked about, that there are some benefits to using machine learning. So efficiency, potentially if you can make predictions to a certain standard, that will free up clinicians to spend more time on other high value sorts of tasks. And if the predictions are accurate enough, they're going to have a lot of value just in themselves. As well as accuracy, I think another interesting point is that machine learning, you can make predictions and you can attach a number to the predictions. So it's not just saying, yes, I think it's likely the person has a disease. It's saying this person has a 76% chance of having the disease. And if you can put a number to it, then you can develop policies based on that number. So quantified predictions allow all kinds of different sorts of decisions to be built on top of that. And then the last one is it's a little bit like efficiency, that potentially you could consider a lot of different diagnoses if you've got a machine learning system, possibly more than a clinician would have time to actually consider themselves. Okay, that's a very brief, quick tour of machine learning. Next, we're going to talk a bit more about the application side of it. What sorts of success is it having today? So I mentioned earlier, alluded to this machine learning algorithm called a deep neural network, which is this picture here. They've suddenly sort of burst on the scene in some ways, become very popular, a lot of news, a lot of discussion. And that there's reasons for that. One of the reasons is that the amount of data that's available is really increased in the last 10 years. So the amount of health data, images, health records, there's a lot more than there used to be available. All of that can be used to capitalise and build neural network models out of. Computation power has also increased a lot. So there's this particular piece of hardware called a GPU, graphics processing unit, that can make it all a lot faster. So you can handle large amounts of data, calculate extremely fast. Plus there's a lot of smart new algorithms as well about how to build these networks and make them optimize them in different ways. So this is this has been the trend, and the sorts of things people are using these machine learning algorithms for. Radiology is one example. So there's a company, Enlytic, who's done trials, and they're saying that they've got a very high level of accuracy on predicting a very difficult type of bone fracture from X-ray images. So using their particular deep neural network technique, they're saying they can achieve a 97% accuracy versus a human at 85%. In another scenario, breast cancer, breast cancer scenario. This is work from Harvard. They did a trial looking at images of lymph nodes in breast cancer biopsies, and they found that they could get the neural network to make predictions at 97%, which is a little bit higher than the radiologists that they were comparing against. And then they put them both together, and they found that they could do even better. The last example there is on melanoma prediction. So there was, earlier this year, there was a paper in Nature. Some researchers from Stanford showed that you could, it was possible to use machine learning techniques to do highly accurate prediction about whether a skin lesion was cancerous or whether it was benign. And they compared against board-certified dermatologists and effectively showed that the algorithm was making predictions that were on par with the human experts. And what was particularly interesting about this last study was that they trained the neural network using images of skin lesions, as you'd expect, but they also trained it with all kinds of other images. So they trained it with images of cats and dogs and cars and aeroplanes and frogs and all kinds of things. And the reason they did that was they were trying to teach the algorithm how to distinguish between different types of objects under different types of lighting conditions, different orientations. So they're effectively teaching the algorithm what is it like to perceive an image. And once they'd done that part of it, they bolted on top of it the ability to try and distinguish between different types of skin lesions. So that was a paper in Nature earlier this year. Just to give you a different flavour of a different type of deployment of machine learning, this is a project I've been involved in myself with colleagues from the Eye and Ear Hospital. This funny looking thing in the centre is actually a temporal bone, so it's a bone in your ear. And if you're having a cochlear implant or you're having ear surgery, then the ear surgeon will be drilling this bone in your ear to make space for the implant to go in. Now you can imagine it's pretty important to get it right. You don't want to drill in the wrong place, you don't want to make a mistake, and that's why they have a very rigorous training regime for people to qualify in this type of surgery. But in practice, it's difficult to find enough real bones to practice on. It's difficult to find clinicians to oversee all of the training that's required. So the possibility here is you could train medical students using a virtual surgical program. So the participant down the bottom, he's got some 3D goggles on. He's looking at the operation on his laptop, and he's moving a drill around that's a haptic drill. And the key thing here is that while he's doing it, the computer is talking to him. The computer is giving him advice about how well he's doing. So the computer is using machine learning, and the purpose of the machine learning is to assess the expertise of the trainee who is actually doing the operation. And based on its assessment of his expertise, it gives him feedback, tries to guide him in a particular direction. So this is another type of area in health where it's really interesting to think about the use of machine learning. All right, I'm going to hand over next to Karin again for the examples on text.
So as I mentioned, I work in the area of text, and in the health context there are many unstructured textual resources that are important, and probably one of the most important is the clinical narrative or the clinical notes that are written about a patient. And this is another area where we can both apply machine learning in order to help us make sense of this data and actually use the outputs of the analysis as input to other predictive algorithms. And we're using text analytics, you might call it, as a fundamental tool in our ability to deal with clinical data. So just as an example, here we have an outtake of a patient clinical narrative, and we have a number of things that are described in this text. One of the things that we can do is to try to apply strategies for detecting concepts of interest. So in this case, I've highlighted a few that are relevant, things like shortness of breath, things like the demographic details, 68-year-old female, cough, particular aspects of laboratory results are in here. D-dimer was positive. We have drugs in there, morphine, also breathing treatments, and so on. So we have a lot of concepts which are medically important, which are captured here in the text. And arguably, they may not be captured anywhere else in the clinical record. So the information that's available in the text is very important for characterizing the patient. So if we're going to be thinking about building models of what's going on with our patients, ignoring this sort of information means that we're losing an opportunity to have a much more kind of subtle and nuanced view of the patient. Now, that first step of trying to capture particular concepts allows us to group things together into types of information. So we can distinguish things like symptoms from test results and from therapies by applying categorization or classification strategies. And those then can, as I mentioned, be the input to particular sort of a representation of what is going on with our patient. The other thing that we can do along the way is to try to recognize some of the variability in the way these concepts are expressed. So at the top here, we have shortness of breath and dyspnea, and actually those are synonyms for each other. And if we have strategies for recognizing that different terms or different phrases actually mean the same thing, then we can normalize some of the variation. And in fact, if you look at natural language, one of the sort of amazing aspects of working with text is how creative people are at saying the same thing 100,000 different ways. I have some examples which, if anybody really cares to know, and Andy in the audience is intimately familiar with the myriad ways that a simple prescription for a tablet can be prescribed. It's quite remarkable, actually, the creativity of our clinicians. Now, arguably, the concepts that we can detect using kind of the terminology that we expect to find actually misses a huge part of the clinical puzzle. And if we read through a little bit more of the text, we actually find that there are some very nuanced details that are available in this text that we really need to pay attention to. So things like progressively getting worse, it comes on with any kind of activity whatsoever. This is information that the clinician bothered to write down. Why? Because the fact that it was a progressive change as opposed to an acute change is information. And now, if you can imagine a transition to an electronic health record, which is basically a bunch of drop-down menus and short little info boxes, there would be nowhere on that form to put that kind of information in. And actually thinking about anticipating all of the characteristics that are relevant to a clinical situation is impossible. We can't put them in drop-down menus. And so that means that we need to be able to work directly with this text. So what I like to think about is strategies for transforming this natural language into a representation that our computers can work with and that our algorithms can use as features that allow us to make predictive models. Just to give you some examples of some of the projects where we've been working on this, and I'll just note that a lot of this work actually needs to be attributed to colleagues at NICTA, but they're nice examples, so I thought I would include them. So one project that has been worked on is extracting information from pathology reports. So pathology reports are written in natural language. They're written by specialists who examine the laboratory data, and there is critical information in there. So if we're interested in staging a tumor, for instance, that information is probably embedded in the pathology report somewhere. The key information about the size and the complexity of the tumor is in there. And so we can develop strategies for pulling out those key facts, the kind of tumor rating facts, from the natural language, and then presenting them in a structured way. then we can even imagine taking that a step further and building alerting systems which essentially say, right, if we've detected that there's evidence of a tumor in this particular scan, then we can flag that with a clinician so that it can be acted upon more quickly. Another context in which there was work happening is in the area of invasive fungal infection, hospital-acquired infections, where, again, there's a report that's written on the basis of a CT scan, again, written in natural language, because guess what? That's how humans communicate with each other. So it's a natural way of communicating. And at NICTA, there were algorithms that were developed that allowed the transformation of all of that natural language variability into a structured report. And finally, more recently, we've been working with Alfred Health to attempt to identify records in their large electronic health record system that correspond to particular diseases, using information, again, in pathology reports, radiology reports, and clinical notes where they're available. And this can be a useful tool, for instance, for identifying patients to recruit into clinical trials, or simply to just keep track of how many patients you have that correspond to particular clinical categories. Okay, I wanted to come back a little bit to some of the kind of broader applications of machine learning. And one kind of methodology that exists in machine learning is called clustering, which is essentially an unsupervised, in other words, we don't have examples necessarily of how to group people together, but it's an unsupervised algorithm for trying to group people together. The idea being that we have all these people, they have different characteristics. We have purple people and gray people and blue people. We don't know that we have those kinds of people until we start analyzing them and measuring their similarity using some quantitative metrics. And once we do that, then we can organize them into clusters of like for like people. And the reason this is important in the clinical context is because we want to be able to take our patient that's sitting out there and try to recognize who is like my patient in order to help us guide treatment decisions. Let me elaborate on that just a little bit. Imagine that we have a clinical situation. Let's say we have a 55-year-old woman. She's of Vietnamese descent, and she has asthma. You're her doctor. You've just learned that she also has high blood pressure. Vera's case, unfortunately, doesn't fit with any of the clinical evidence that we know about. There's no medical literature on hypertension medications for middle-aged, asthmatic, Vietnamese American women. You want to treat her hypertension, you have no guidelines. So Vera is sitting in the exam room. What do? So if there's a clinical guideline available that's based on a randomized controlled trial, that's what we would do. We would pick that clinical guideline and use that to guide our treatment. But I've told you that there are no clinical studies that correspond exactly to the characteristics of Vera. And so what can we do? Well, perhaps what we can do is imagine having access to a very large database of medical records and try to find our patients like me approach, to find other patients that are like Vera. So we find our cohort of similar patients, and then we can apply machine learning, predictive modeling, hypothesis testing. We can compare that cohort of patients to the other patients that we have information about in order to test a hypothesis about different treatment options that we have. And once we do that, then we can use that to help us make a decision. So this is really the idea of taking advantage of these large data resources that we have in the clinical space and using it for making decisions that otherwise we just have to rely on intuition and, of course, years and years and years of medical training to make. Okay, so one question, of course, is how we can build this. How can we execute this vision? We've talked to you about a lot of amazing things that are happening. But there's some fundamental things that have to happen in order for this to become a reality. One of the critical factors is, of course, the data. If we're going to make decisions using data, we have to have the data. Now, it's a sad reality that in Australia, a lot of our clinical information is still on paper. So step number one is we need electronic data. And if you tell me we can do optical character recognition on handwritten doctor's notes, I'm going to tell you to come back in 5 years when you fixed the data problem. I'm not working on it. You can go right ahead, I'm not. We also have to think about coming up with standardized ways of describing the data. So if we have a database that has a blood pressure reading in one field, we need to know that it corresponds to a blood pressure reading in a different database in a different field. How do we do that if we're describing them? It's BP over here and it's blood pressure over there. I don't know that they're the same thing. A computer certainly doesn't know that they're the same thing. And so we have to have language that allows us to describe our data in a way that we can consider it as a whole entity. And of course, we have to think about privacy protecting data linkage. So if we have different resources where we have data about patients, we have to have strategies for bringing them together. This in turn requires data governance. We have to have policies around consenting patients into agreeing for their data to be reused and thinking about how we can manage and protect their privacies. Finally, we need infrastructure. So I heard the analogy of if you have to get 300 people from one side of the river to the other, you don't want to take 300 rowboats and take them across one at a time. You want to build a bridge. And this is essentially what we need in the health space. We need to have platforms that allow us to share data in ways that allow us to do the whole cycle of the learning health system. Not only connect the data together, but use it to do analysis and then feed that back into the decision models and the implementation in clinical practice. It has to be a common resource that allows different levels of information to be shared. Now, one particular challenge that we're facing, and I think where we've seen success in machine learning, a lot of the applications that James described involved image processing, and deep learning in particular has shown some very, very strong effect in the image processing context. But once we start looking at broader kinds of clinical data, we have some challenges that the algorithms are not necessarily ready to deal with. And specifically, we have a huge amount of variability that we have to think about. So there's going to be variations in the amount of information that we have available for one patient as compared to another. There are going to be variations in exposures to various risk factors. There are going to be errors in data entry. And so basically, the data is going to be noisy. It is noisy. We already know it's noisy. And our algorithms at the moment do a reasonable job of trying to sift through all of that noise and find the key predictive factors, but they're not completely robust to that variability. And this becomes particularly important in the context of the heterogeneous data, the broad ranges of the kinds of data we can find. As I said, everything could be relevant. Behavioral choices, how many glasses of wine you drink, how many cigarettes you smoke. We know that these are important factors for our health, but they're not captured in your clinician's office. Those are things you're doing at home or at work that you have to report to your office, to your clinician. We can have these 24/7 sensors that are collecting data in real time, but then you only see your doctor once a quarter. How do we align that information? It's completely different levels of information, and we just don't really know yet the best strategies for doing that.
All right, I'm going to cover a couple more challenges and then we're going to wrap up. The challenge on this slide is the interpretability challenge. So we've talked a little bit about these machine learning algorithms. They produce these models that we can use to make predictions, but some of them are very opaque and hard to understand. So in the example there, we're feeding in an image into a machine learning algorithm, a neural network, and we can't really understand what the network is doing. We just get a single output at the end, and the output is that there's an 85% chance that the tumour is cancerous, and there's a recommendation for radiation treatment. So we can see the output of the algorithm, but do we trust the algorithm? So if you were a patient and you were told that there's an 85% chance of this outcome, would you have the treatment or would you not have the treatment? You'd probably ask, well, why did it say that? What are the reasons the algorithm told me is making that prediction? And one of the challenges is that a lot of these algorithms are difficult to interpret. You can't, they give you an answer, but you don't know why they gave you the answer. You can't interpret the actual steps in the reasoning very easily. So trust is a big issue, and then even going beyond trust, you'd like to, if you like, have a conversation with the algorithm and ask it, what are the limitations in your reasoning? Could you have done it differently and adjusted your prediction in some way? So interpretability is a big challenge, and it's even becoming a regulatory issue. So from 2018 in the European Union, there's something called the right to explanation. So if you live in the European Union, you're going to have the right from 2018 to demand an explanation about predictions that are made about you. So if you get denied for credit or you get assessed for a particular type of health risk, you'll be able to ask for a meaningful explanation about how that assessment was made. And it sounds great, but I don't think anyone really knows how to do it yet. Very big challenge. Reusability is another one. So we've talked about all these different algorithms doing great things in a particular context. So how do we have algorithms that work well here, and how can we put them over here and also get them to work well as well? So you might have a system that's very good at predicting breast cancer. It's not necessarily the case that it's going to be good at predicting some other type of cancer. There'd be all kinds of effort involved in adapting it from one context to the other, and that's also a challenge about how you actually do that adaptation and the amount of work required for that. Thorny issues, I won't say much here except to point them out. Liability. So imagine you've got a machine learning algorithm and it makes a wrong prediction. What happens? Patient gets into trouble. Who's responsible? Is it the clinician? Is it the algorithm? Is it the hospital? Really hard to say. Fairness is another issue. People have shown that algorithms can be biased. These machine learning algorithms can be biased against minority groups or particular types of groups. So if you've got a machine learning algorithm that's making it biased against these groups, it's a problem. Also the ethics. So the data problem that Karin alluded to. If we're all having our data analysed by these algorithms, what are the boundaries? Suppose I don't want my data to be used as training in a machine learning model. Can I stop that happening? Do I have to give consent, or is it something that's really for the common good? These are sorts of things we need to work through. So finally, Karin described a scenario of Dr. Digital using machine learning, and it was really exploring the question of what does success look like for machine learning and health. And I think it depends very much on your perspective, this question. So the clinician might have a perspective, the hospital will have a perspective, and the patient will also have a perspective. And we need to think about how we measure success from all those perspectives. I think this vision of having a dialogue with the machine learning algorithm is a really powerful and attractive type of vision. So a conversation about why it recommends a diagnosis. And then there's also the broader workforce training issue. So if machine learning is going to be a pervasive part of our lives in health, and clinicians and other health professionals are going to be working with machine learning, using machine learning Should that affect how we train our health workforce? Should that be a compulsory part of the medical curriculum is something to think about. We also want to acknowledge, just on this slide, the many fantastic partners we've worked with, so funding bodies, as well as hospitals and other entities, as well as individuals from those hospitals, without whom we couldn't have done any of this research. So thank you to all, and I think we're very happy to take questions as well. Thank you.
Well, thanks, Karin and James, for that really exciting presentation. It's so amazing how machine learning is already improving our daily lives, and the implications it could have on our medical field is just amazing. You raised some really important implications, but also some big questions to ask. So hopefully we see those questions answered in the future research.
So this talk is another great example of how convergence of science and the ideas is actually radically changing medicine and healthcare. It is the revolution we are living through, so it is important to understand the forces that makes this possible.
Cynthia Wellings, Ultimate Education. I'm a nurse and I believe that this kind of technology is incredibly important, but it's very functional and it's very reductionist. And there's one theory of nursing that says that the nurse is a healer and holistic care is incredibly important. And what worries me about this logical system of interpreting health is it must not be blind to the concept of health as a total part of a human being and their meaning. So fact and meaning are not the same thing. And what worries me is that we end up with a very reductionist model that says you have this cardiac condition or you have that. But what that means for the Vietnamese woman who's got asthma or whatever else, or cardiac condition, and what that means to the family and her life must not be omitted in this process. So somehow the reductionist model has to also be expansionist and has to encompass so much more.
Yeah, I think you're absolutely right. We were very careful in our scenario not to say that the digital doctor had the final say, and that the role of the clinician in that context is perhaps one of considering those broader factors and what's it going to mean if we pick a particular treatment option for your day-to-day life, for your quality of life, and all of those broader factors. And I agree with you, we don't want to get everything down to a number. It's not about that. But I think what we're trying to say is that this is one tool that we can incorporate into the healthcare system, which will improve the overall ability to respond to individuals. And there's this trade-off between individuals as kind of a quantitative representation and individuals as humans. And clearly the objective here is to improve health outcomes for people. And thinking about how to embed that into the healthcare system is one of those thorny issues. Just really, we have to consider what the role is for these kinds of technologies. And I think, on this slide, we added in, what do patients want? I think that's a really important part of the story. I suspect patients probably don't want a computer that's telling them this is what's wrong with you, without that broader conversation.
Yeah. My name's Chris. I'm a medical student from Melbourne Uni. I guess just to continue on that last question, in the scenario that we were given at the beginning, the digital doctor takes the history, does the examination, makes the diagnosis, and then the pulmonary stenosis, and then comes up with a management plan. I guess in radiology you have these learning systems making the diagnosis as well. For the last 7 years I've been trained to think in a way to make the diagnosis, come up with the diagnosis, and then give a management plan to the patient. What becomes of the role of the doctor in making the diagnosis and doing thinking 30, 40 years from now?
Yeah, I think it's a really good question, and it comes down to this sort of granularity question of what you're asking the machine to assist you with, and what you want to do with your own judgment, or whether you could both be making the diagnosis together. I'm not sure that that these sorts of issues people have really worked out yet, and it might be that it's on a case by case basis for particular types of medical specialties. It happens a little bit like this. Other specialties it happens a little bit like that. This was part of the reason we, on our final slide there, suggested, I think considering it early in the education is really important. So you don't want this to be an afterthought once you start your working life, but if it's something you've experienced during your medical training all the way through, then it might not seem so unnatural.
Yeah, hi. I'm Verspoor here from IBM Research here in Australia. So thanks very much for a very high-level overview of what you guys have been doing. My question is very simple. You have a very long list of acknowledging the people in the parties. Can you please tell me basically where are you in this journey so far as of today?
Well, so the examples that we gave of specific applications are things that we're actively working on. So the surgical training, is it being used?
Yeah, absolutely. Yeah.
And so a lot of the collaborations here some of them are about specific projects. So for instance, I'm working with Graham Pitson, who may or may not be in the audience. Sorry, I can't quite see. At Barwon Health, and we're looking at clinical letters that are being sent from oncologists back to general practice providers for a given patient, summarizing the course of the patient's cancer development, and we're trying to extract particular features of that are relevant for tracking the patient's condition. And so, we're actively working on these things. Now, to James's point about how the application of machine learning has to be a well-defined task, at the moment, we are working on individual well-defined tasks, and we're trying to take a step back and get to the point where we can have broader system-level change. But to do that, we need some things in place which are not quite there yet. So we don't have broad electronic medical records in place in Victoria. This is the first stumbling block to doing anything digital, right? So, there are limitations to what we can do. On the other hand, I have another project which is being funded by Victorian Department of Health, looking at the administrative data sets that are collected, the Victorian Admitted Episodes data set, which captures every hospital admission in Victoria, and we're doing comorbidity studies with that data. It's quite a large data source. It goes back about 20 years, and although it's only diagnostic level information, we don't have all the detail of the patient laboratory results or anything like that. We just know this patient was admitted to hospital and had this diagnosis, but we can already extract patterns and make predictions about recurrences and those sorts of things.
All right, thank you for all the questions.
So as researchers and students that are passionate about science communication, we really appreciate and we really value the Convergence Science Network in providing public and regular opportunities to engage with incredibly dedicated scientists and researchers like these with us. Sharing their work both inspires us and it also encourages us to understand the efforts that are being made to tackle the many healthcare and medical related diseases and conditions.
As young researchers, we appreciate the dedication and commitment biomedical scientists make to growing mankind's knowledge and understanding the diseases. It takes many years of effort and associated highs and lows that goes with this activity, which is shielded from public view. Now, we believe that it is important to acknowledge the efforts of our many biomedical researchers, and in particular, those who have supported the network over 8 years. And we would like to take this opportunity to thank them for their services and dedication to the society.
And finally, we'd like to take this opportunity to express thanks to all of our network's partners for their generosity in making these events possible. It's thanks to their commitment to public engagement with science that we're here this evening. Please join us in thanking the Convergence Science Network partners for their support and what they make possible.
Thank you for your attention. It has been a privilege to be your host and to hear about the possibilities to improve health from advances in data analytics and machine learning. Please join us in thanking Professor Karin Verspoor and James Bailey for sharing their work and ideas with us, and we wish them great success in their future research.
We hope to see you at future events, and thank you and good evening.